Okay, it's right at 11 o'clock, so we'll go ahead and get started while people jump on. My name is Brian Hendricks. I'm the Quality Improvement Data Analyst here at USET. And we'll start with Emily giving some basic housekeeping information.
Good morning, good afternoon, everybody. For continuing education, medical or nursing credits, I have shared a link in the chat, and I will continue to do so a few times throughout the hour. Towards the end of the hour, I'm going to include a different link that will be anonymous and for evaluation purposes, so we can get some feedback on how to improve these calls. And if you have not done so already, please mute yourself, and please do not take offense if one of us mutes you if you've become unmuted by accident or something. Feel free to ask questions in the chat. You can either ask them to everybody privately or out loud. And that is all.
Great, thank you so much. We will start today's session with Imani giving updates for the area.
Hello, good morning or afternoon, everyone, and thanks for joining us today. I will be providing our usual update on the COVID-19 epidemiology in our Nashville area or region and review some of the data points that are provided in our USET aggregate surveillance report, which is sent out weekly on Tuesdays. Please note that due to the holidays, no reports will be sent out next Tuesday, but we will resume the following week on December 29th. So be on the lookout. So the following slide displays the number of new positive test results, the cumulative total of positive test results, as well as a 7-day positivity rate or percent positivity for the week of December 7th to December 14th, so this past week. And these numbers were obtained from the 27 sites that are currently reporting COVID-19 testing data to IHS or the Indian Health Service. And so for this week, the number of positive COVID-19 tests at reporting facilities in the IHS Nashville area in the last week was 193, while the cumulative total of positive COVID-19 tests was 2,072. And the 7-day positivity rate was 7.4%. I do want to note that the percent positivity did decrease from what was reported last week from 9.4% to this week's positivity rate of 7.4%. And prior to last week, our positivity rate had remained at around the 6 to 7% range. So there was a notable increase in the rate for the last week. And I've mentioned this previously, but the percent positivity is a good data point to use when you're doing a lot of testing on asymptomatic individuals. And as that percent increases, it indicates an increase in the number of positive COVID-19 test results, while a decrease would suggest the presence of more negative test results. Okay, so the slide you're now seeing shows the number of new positive COVID-19 test results from week to week over a 12-week period. Again, for this week, the number of new positives for our Nashville area was 193, and a clear increase from the previous week to this week is reflected on the graph. In general, we have seen an increase in the number of new cases over time, but it does appear that since the week of November 23rd to November 30th, that we've seen more of a rapid increase or climb in the number of positives. That being said, it is crucial that we all continue to practice our 3 W's, wearing a mask, washing your hands, and watching your distance, our social distancing to decrease or slow the spread of the virus. And I also feel that it's important to note that although we have reached a great milestone with the release of the vaccine, these measures will still need to be continued and used. Okay, and so this graph shows the rate of new COVID-19 cases per 10,000 by USET counties, USET states, and the United States. And we have provided you with a 12-week period or time frame for this information as well, so that you can follow the trajectory of the outbreak across time. Please note that these rates are not limited specifically to tribal citizens. And so specifically for this week, the PERCTA, Purchased and Referred Care Delivery Area, or USET county rate, was reported as 41.83 cases per 10,000, while the USET state rate was 37.07 cases per 10,000, and the United States rate was 44.97 cases per 10,000. As last reported, the USET US rate continues to be the highest, followed by the PERCTA or USET county rate, and lastly, the USET state rate. So the rates are increasing across the board, and the USET county rate surpassing the USET state rate suggests an influx or the presence of widespread COVID-19 infections at the county level there. And lastly, just a reminder that we do have the COVID-19 surveillance tool available for you to use. If you would like to request a RedCap account to get access to that, or if you require any general assistance, please feel free to reach out to us at usetinc.org. Thank you.
Great, thank you. Do we have any questions for Amani? Okay, we'll pass it off to Christy to give a few comments.
Thank you, Brian. So I just have a couple of comments. I know it's been a while since I've presented on the ECHO session. Imani's done a fantastic job of taking over the data and statistics. You know, I guess I had to pass that torch at some point in my life. So thank you for that, Imani. So this week, and I guess I'll just share a little bit of a personal story. It really hit me pretty hard. When I saw on Facebook, because I follow the tribes on Facebook as much as I can, when Cherokee, they posted that they had received their Pfizer vaccine, and I honestly did not expect this reaction from me, but I teared up because I just felt this overwhelming sense of relief that, okay, something is happening and we're moving through this. And I just thought, okay, I know that this is not the end of this. It's going to be a long, hard trek to keep going in this. But for tonight, I'm just going to enjoy that relief and just feel it and sit with it. But I do want to say, I'm hoping that you all have the same sense as well. However, I just want to caution everybody not to let that relief make an impact on the measures that we still need to put into place. This is not over yet. We still have a whole lot of work to do getting the vaccine out there. IHS has done a phenomenal job, and the Nashville area office has done a phenomenal job with coming up with their vaccine distribution and work coordinating with the tribes. Social distancing measures still need to happen, all hand washing, limiting group sizes. But there's an end in sight, it seems like to me, and that is a relief, and it is much welcome at the end of the new year, and gives me hope for the new year. So I hope you all have a sense of that as well as we move forward in our efforts to combat COVID, because this has been a terrible year. I think everybody agrees. And so I will not be sad to see 2020 go, and I will be happy to ring in 2021 with hope for the new year. And I just wanted to share that all with you. We've got some resources coming out to you via email that will go to the tribal leaders, health directors, those sorts of things by the end of business today. We will be available if you need us over the break. I will be monitoring the USET EPI email address, usetepi@usetinc.org. So please use that one. That way we know we've got somebody on the team will be checking it. So if you've got an emergency, please use that. And then we can get back to you and help you as soon as possible. But I just wanted to say thank you to everybody. I think everybody has done a phenomenal job in just a really crappy year. So Happy New Year to you, and I'll pass it off to Dr. Brown, and so he can give you some brief updates. Then we'll enter into just basically a Q&A. I invited USET staff to this as well, just because we all have differing knowledge bases going forward. So don't feel like that if you're not a provider or you don't have all the information that you can't ask a question. That's what we're here for. The area office and USET have agreed to host a similar format specific for your tribe and maybe do a town hall for your community. Shoot us an email and we can get that booked. It will not be until the new year that happens. So if that's something you'd like, just contact us and we'll coordinate schedules and get that moving. So Merry Christmas, Happy New Year, Happy Holidays.
Great. Thank you, Christy. Just a reminder to, if you're interested in continuing education credits, to fill out the survey in the chat box that Emily posted. It's just a very brief attendance survey. And I will turn it over to Dr. Brown.
Okay, thank you, Brian, and thank you, Amani and Christy, for your presentations. They were excellent as usual. I have just a brief presentation today, or at least I'm going to try to make it brief, although there's a lot of information. It's amazing how fast new things are coming out every day. It's just phenomenal. It's really difficult to keep up with everything that's coming out every day. We are going to have a panel question and answer after this, and I really want to thank in advance my colleagues from the Nashville area office, Dr. Johnson, Captain Boykin, Captain Bartlett, and Commander Wyatt. Is Commander Wyatt on with us? I didn't see his name there, but anyway, I'll go ahead and launch into the presentation. So next slide, please. So unbelievably, we've been in this pandemic now for 283 days. I have a couple of things to talk about this morning. One is the new home test for COVID-19 that's been given an emergency use authorization. And then I'm going to talk a little bit about the two vaccines, the one that has an EUA and the other one that probably will have an EUA, if not today, probably tomorrow morning. And just do sort of a comparison and contrast of those two vaccines. Next slide, please. So the new Ellume, I think that's the way you pronounce it, COVID-19 home test was just given emergency use authorization on the 15th this week. And this is the very first test that is available for home use. There have been a bunch of other tests that are put out that say they're for home use, and really what they're for is home collection. You know, you collect the sample and then you have to mail it off to a lab, and probably, days and days later you get an answer. This new test actually allows you to do the test at home. It's a little bit like doing a home pregnancy test, and you get the results within a few minutes. It is an antigen test. It tests for the presence of the SARS-CoV-2 nucleocapsid. It's actually approved for self-collection in people who are 16 years old or older. And then adults can collect it in kids that are 2 years and up. It's just a mid-turbinate swab. In other words, you stick a little swab up into the nose. It's not all the way back like, those nasopharyngeal swabs. I've had 2 of those and they're not very comfortable. It does require you to have a smartphone and download the app from the company. The test is a lateral flow test, which if you're familiar with either the rapid strep, rapid flu, home pregnancy test, those are all lateral flow tests. You put a sample in, you put a few drops of liquid, and a few minutes later, the test is read. In the case of this one, it's actually a little electronic reader inside the single-use test. It has a battery, and it will send the results to the company and then it sends it back to your smartphone, either positive, negative, or something went wrong, you know, and the test is not valid. Next slide, please. Well, how accurate is it? Just from the results of testing, it looks like it's not a bad test at all. It had a 95% positive agreement with the gold standard PCR test for all the subjects they tested on, and they tested it on about 160 people. Had a 97% negative agreement, so you know, not that many false positives. It was better for people who were having symptoms, 96% positive agreement and 100% negative agreement. For asymptomatic people, it was not quite as good, but still in the 90s on average. Those numbers in the brackets are the 95% confidence intervals for those of you who are statistically inclined. Next slide, please. So it's as I said, it's a complete all-in-one test. It has an internal control system. There's a battery. They recommend that that be removed and disposed of properly when you finish with the test. A couple of things about cross-reactivity. It is most likely cross-reactive with the SARS-CoV-1 virus. That's the one that was around back in 2003 and 4. That there haven't been any reported cases of SARS-1 in the last 16 years or so, I think outside of a couple of lab infections. So it's unlikely that, you know, the positive test would be due to SARS-CoV-1. The company also says that it's possible but unlikely to be cross-reactive with another human coronavirus, the HKU1. The other 3 human coronaviruses that it was tested against, it was not cross-reactive. So it's unlikely that a positive test would be a different coronavirus. It was also tested against a bunch of other respiratory pathogens and found not to be cross-reactive. Next slide, please. So I want to switch gears now and talk about the 2 COVID vaccines, one that's already in use and the other that will almost certainly be in use by next week. So December 11th, that was only a few days ago, 1 week ago, the FDA gave an emergency use authorization to the vaccine that's made by Pfizer-BioNTech. And then yesterday, the Vaccine and Related Biologic Products Advisory Committee voted to grant emergency use authorization to the Moderna vaccine. Now, both of these are messenger RNA vaccines. They're very similar to one another, and both are pretty similar in efficacy and safety profiles. I'll point out some minor differences there as we go along. Next slide, please. So just for those of you who may have missed some other talks I've given about how the vaccines work, I'll go through that very quickly. So these are RNA vaccines, and in cellular organisms such as humans, you all know that our genetic code is carried in double-stranded DNA that's located in the cell's nucleus. Now, when the cell needs to provide instructions to the ribosomes that are located out in the cytoplasm to make proteins, the DNA does that not by coming out of the nucleus, but rather by making messenger RNA. So the information that's coded in the DNA is then transcribed into a single strand of messenger RNA. The messenger RNA then goes into the cytoplasm where it encounters the ribosomes, and it is the code that it has is then translated to make proteins. Now, from the nucleus to the cytoplasm for messenger RNA is really a one-way street. After the messenger RNA is used by the ribosomes to make whatever protein they code for, they basically are degraded, and it doesn't go back to the nucleus. So messenger RNA, which is a single strand and inherently much more fragile than the double helix of DNA, is quickly degraded. And I think that's an important safety feature of these vaccines. Next slide, please. I'm sure you've all seen a bazillion pictures of the SARS-CoV-2 virus. This is an artist's rendition. And the important thing here is the spike glycoprotein on the surface of the virus. The virus's genetic material is contained inside the envelope, and then these spikes on the outside. That's how the virus attaches to our cells and gets inside us to do its dirty business. Next slide. So how do RNA vaccines actually work? Well, there's a strand of messenger RNA that has been made in a lab that codes for the viral spike protein. So in other words, this has the information for our body's cells to make spike protein. That's all it makes. It doesn't make any of the rest of the virus. It doesn't make the virus's genetic material and doesn't make the envelope or anything else. So the tricky part then is getting messenger RNA, which, as I said, is very inherently fragile, inside our cells. And the way that that's finally been done is they figured out a way to package it in lipid nanoparticles. In other words, tiny, tiny little fat bubbles. And then that's injected. It goes inside the cells because the lipid nanoparticle allows it to dissolve through the cell membrane. Once inside the cell, the ribosomes take it up, the messenger RNA, and they use that to make spike protein. The spike protein is then secreted by our cells, and it runs into our immune system. The immune system recognizes the spike protein as something foreign. It starts making antibodies and cytotoxic T cells that are targeted for this spike protein, so that if you actually come in contact with the virus and get infected with SARS-CoV-2, the body's immune system says, hey, I've seen this before, and it produces antibodies and T cells that then kill the virus, or killing is probably not the right word. It blocks the virus basically and doesn't allow it to get inside our cells and reproduce. Next slide, please. So that's kind of in a nutshell how it works. Well, what about these two vaccines? How are they alike and how are they different? Well, in terms of their effectiveness, they're almost identical. The Pfizer-BioNTech vaccine, which is known as BNT162b2, that's just the name they gave to the vaccine component. It was shown to be 95.0% effective. Moderna's vaccine, otherwise known as mRNA 1273, 94.1% effective. You can see their 95% confidence intervals in the brackets are overlapping, virtually the same in effectiveness. As far as in older people, it's a little bit tricky here because the Pfizer-BioNTech vaccine was 93.7% effective in people over 55, whereas the Moderna vaccine was a little bit less effective, 86.4% in people over 64. So it's not exactly an apples to apples comparison, but as you can see from their confidence intervals, you know, they're pretty close. In terms of side effects, the Moderna vaccine may be a little more reactogenic, but really both vaccines had very few people that experienced grade 3 severe side effects. A grade 3 side effect is a side effect that interferes with your daily activity. So it's bad enough, you know, that you might call in sick. By far the most common side effect of both is a sore arm. So I got vaccinated with the Pfizer vaccine at Cherokee Hospital, where I work part-time, on Wednesday. By Wednesday night, my arm was slightly sore. Thursday morning, you know, when I woke up, I said, my arm's sore. When I woke up this morning, it was pretty much gone. So, you know, sore arm, big deal. The approved age is a little bit different. Pfizer has data showing that it works in 16 and older. Moderna only tested it in people 18 and older. Both companies are currently testing it in 12 and up. So we may soon have a revision in that age to go down to 12. And that would be great. Next slide, please. So what about the dose? The Pfizer vaccine is 30 micrograms. Moderna uses 100 micrograms of their product. That equates to 0.3 cc's and 0.5 cc's. The Pfizer-BioNTech comes in 5-dose vials. Moderna is 10-dose vials. Pfizer-BioNTech requires that you add 1.8 milliliters of sterile saline to reconstitute it. Moderna, you just thaw it out and use it. They both require 2 doses. The difference is Pfizer-BioNTech is 21 days apart and Moderna is 28 days apart. Next slide, please. So what about these temperature requirements? I'm sure you've all heard a lot about how they have to be kept really cold. Well, both of them are stable frozen for 6 months. The difference is the Pfizer-BioNTech has to be kept at 70 degrees below 0 centigrade, whereas Moderna is more like, you know, your home freezer minus 20 degrees centigrade. Refrigerated, the Pfizer vaccine is good for about 5 days in the refrigerator. Moderna's is stable for 30 days. Room temperature, the Pfizer vaccine is stable for 6 hours. Moderna's is for 12. However, once you pierce the vial of either of these products, you have to use all the doses in 6 hours. And the reason for that is neither of these contain any preservative. So just as sort of an infection control issue, you need to use it within 6 hours. Now, you may wonder why the difference, if these vaccines are so similar, what's the difference in these temperature requirements? Well, I think, and I've actually read that it's the difference in the lipid nanoparticles. Both contain 4 different lipids, 2 of which are pretty similar, but the other 2 are different. And that probably accounts for their temperature stability. It may also account for the difference in their reactiveness as far as side effects, but that's speculation on my part. Next slide, please. So that's really all I had today for a presentation. We wanted to leave plenty of time for question and answer. And yeah, that's a picture of me. I'm getting the vaccine there by one of our able nurses at Cherokee Indian Hospital, Charles Spray, who's been a colleague for many years. I was quite honored that he was the one that gave me my immunization. And I do have his permission to use the picture. So anyway, we'll take questions. I do want to say to all of you, thanks for all that you do for all of our tribal nations and citizens every day.
Okay, we'll open it up for questions. If you have any questions, you can type them into the chat, or you can unmute yourself and ask your question. Just a reminder to fill out the attendance survey if you're seeking continuing education credits.
So we'll take questions on pretty much any subject having to do with vaccine, whether it's the vaccine itself, how you give it, the distribution. I can even speak to, you know, what's on the horizon if people have questions about that. And I see Christy says, how bad did it hurt? That's the most important question, right? Well, I can honestly say it didn't hurt at all. I did not feel the needle. I felt just a twinge as it was injected, but I mean, it was one of those things where you go, did I feel something? So really, it didn't hurt at all. And as far as the arm soreness, I mean, I barely noticed it, so not painful.
Dr. Brown, Dr. Brown, can I ask you a question with regards to that at-home test?
Yes, sure.
So it's been approved for emergency use. Obviously, it's like $100, $110 for the individuals to buy this. We've already received some inquiries to Mohegan's PRC department about if we're going to pay for that. Well, because we can't, that's not how we operate. We can't just hand them $100 when they hand us over a receipt.
Right.
Does IHS have any guidance on that?
I might let Dr. Johnson take that question if she doesn't mind.
Good morning. Hi. So to answer your question, everything is so new, and I don't know that we have really had discussions on those home tests and how they will be utilized. And IHS usually, we usually have providers as we're doing our testing. And so I haven't heard a lot about how we will handle that, or if we will be encouraging patients to continue the processes we have in place in which our providers will provide those testing.
Yeah, I mean, we don't encourage that test. We'd rather, we're fortunate we actually have a testing facility on site here. We'd much rather our folks do that than get something at home. But, everybody's, I remember what's the Cologuard, the colonoscopy replacement. That's what people think it is. We don't want to cover that either. We'd rather you be really engaged with a medical professional when you're seeking answers. So, okay, thank you.
Yeah, I mean,
and I was just going to say, I don't know that as we discuss it, because there are going to be areas that are very rural, and this may be the only testing available to get to them, and so that may affect how further discussions are. But just as of now, I'm not aware that IHS will be covering it through PRC.
Hi, this is Roberta. Can y'all hear me?
yes.
Hey, Dr. Johnson. Hey, Dr. Brown. I'm so glad that Carrie had asked that question, because it was in my mind as well, as far as how we would, proceed with that. But thank you for, answering that, Dr. Johnson. We really appreciate that. And I also, of course, I'm from Choctaw, Mississippi Band of Choctaw Indians, and I was one of the recipients of getting the COVID vaccination yesterday. And so I did have, a slight soreness. And of course, this morning it was a little bit sore, but I took a Tylenol. And other than that, no major issues, just slight soreness. And what I like to say is it's just like getting the flu vaccination. So I just wanted to share that with you guys. And thank you all for the information that y'all are sharing. Very appreciative.
Thank you for sharing your experience, Roberta. I think a lot of people, you hear about it on TV and you hear some of the participants in the studies, and now that it's here, we really, like to hear those stories with people that we know and how it really went.
Yeah.
And so thank you for sharing that.
You're welcome. I just wanted to share that with you. Thank you.
Hi, Dr. Brown and Dr. Johnson. This is Nancy from Alabama, Coshada. I have a question. So all the tribes in our area are getting allotted a certain amount of the vaccine. Is there going to be another round of allotment, or is this what we're going to get and we'll have to wait until more are manufactured? Or is there still I guess my question is, since we're allotted a certain quantity, we have to meter the people that we're getting a vaccine, because they have to come back 28 days later to get a second dose. So I guess my question is, are we going to receive any more after we've expended our initial allotment?
I'm going to let Nathan Wyatt answer that question for you. Nathan, are you able to unmute? If not, I can answer it. But I think
Yeah. Hello. Yes. Can you hear me?
yes, we can.
Okay. Great. Yes, you will have your initial allotment of I believe for your site was 100 doses, if I'm not mistaken, and so and you will be able to provide that to up to 100, 100 people. You and then the second dose, the 28 days later, that will be shipped by before before it's due. So you will receive that automatically. So in other words, this first shipment that comes in, you do not have to like only vaccinate 50 people and then use that second 50 for that. No, Moderna will be sending you that second shipment, so you can go ahead and use all 100 doses of this first allotment. And then moving forward into the future, we will have additional allotments and amounts that you'll be able to order. I believe they're getting really close to having this system called VPOP online, where you can actually place the orders yourself for your facility when that's ready. But that may not be in time for this second round. So we may be it may be just like we did this time, where we have to notify NSSC and they place the orders for you. And then we communicate, as far as how many doses and stuff you'll need and how many you'll be receiving. So it's getting close to where you can have that functionality to place the order yourself. But as of right now, it's not quite set up and ready. So when it's time for that second round or second allotment of doses, you will be, one way or the other, you will receive those.
Thank you, Nathan. I'm going to turn it over as well. She'll be able to talk a little bit more about the ordering of the system with the ordering as well. And then the recording of the administration of the vaccine. Robin, are you on? If you're talking, you're still on mute.
All right, can you hear me now?
We can.
All right. So yes, but like Nathan said, we will be getting access to VPOP soon, the vaccine provider ordering portal. And so there are supposed to be some trainings coming out as soon as next week, I believe, on that front. It will give you options to be able to see your delivery tracking and to do the future orders as well as we start getting into more availability of the vaccine. As you know, the very first shipments, there's more of a shortage of vaccine as we try to get it out nationally. And so it will become more of an end user kind of burn rate, being able to order more frequently as we progress into more availability of the vaccine. And the VPOP will be used for that portion. I believe you wanted me to cover a little bit about reporting as well. Is that correct, Dr. Johnson? Okay. So VAMS, every site in the Nashville area should have VAMS, the Vaccine Administration Management System. And that is going to be used for employee health, especially. We do have some COTS programs, commercial off-the-shelf EMR programs like NextGen, Centricity. If you do not have RTMS EHR or a way to transmit the information to the National Data Warehouse that will ultimately go to the CDC, then you will need to be using more than one VAMS clinic. So some sites do have an employee health, a community, and a tribal health VAMS clinic. So some sites will have all three of those VAMS clinics created. And last night, we did send out a training plan and training attestation form earlier in the week for those to learn more about VAMS. You cannot play in VAMS, it's for real patients only. My disclaimer here, it has to be a real patient to register, a real patient to document the administration in there. So you have to use the recorded trainings to become oriented to VAMS, to know how to use it. But do those recorded training sessions. I will note too, that it's the same hyperlink for every single session listed there. You have to drag the bar across the bottom to where the time starts. They recorded as one block 53-minute session. And so there's like little times that you have to drag it across the bottom to start where your role aligns with the VAMS part. Because we do have healthcare providers being one role, but you also have a clinic administrator role and an inventory manager role in there as well for those receiving the vaccine and getting the inventory there. There are some national reports that could be run. There's been some questions about reporting. You do have you do have very limited access to reports coming out of there, but it will track your inventory. So that will be something you'll be able to see in there, and you'll be able to see the second dose in the VAMs as well. So definitely, if you're interested in learning more about VAMs, watch the recordings. If you did not receive your user access last night, reach out to me. I have a couple sites that still haven't turned in their reporting forms. I think there's about 3 or 4. If I don't have the email addresses to create the user accounts, then you haven't get access to VAMs yet. You definitely need the employee health one. There have been lots of trainings about VAMs, and employee health has to stand separate from an official medical record. So they can sign a release, an 810 release form, to get a historical entry into a chart if they are a tribal member that also have an RPMS EHR chart, but there's a lot of little nuances there. So if you have any questions about employee health, let me know. So I won't go into a lot of detail on that front, but you do have the VAMS employee health clinic. Now for tribal sites that may or may not create charts for every single non-beneficiary coming in, you may also need a community health VAMS clinic as well, even if you're an RPMS EHR site. So let me know. I have those built. I just didn't assign the users yet because most of the tribes I've talked to so far said, whether they're a non-ben or a tribal, I'm going to create them a chart because that's my source of record in my policies. So in that case, even non-bens coming in need to fill out the application form so you can create them a chart and be able to document it like everybody else. We are in the process of onboarding one of the patches that's needed to create that HL7 interface in between RPMS documentation and the National Data Warehouse. So Mitch is working hard trying to get all the sites onboarded that use RPMS EHR on that front. We do have the patch. There's just a controlled release on the onboarding where we need an OSU help desk ticket to get each site configured for that last portion of the actual turning on of that interface. So by next week, you should have it. It should be fine. We are awaiting another CPT code activation patch once Moderna does get approved. So there are still a couple of patches pending, but we should have all that before next week, knocking on wood over here. When it comes to RPMS EHR reporting, we are going to have configuration where you're going to have a quick note. A standing order for Pfizer got released this week. So you, if you had Pfizer vaccine, there's a standing order and a pre-vaccination questionnaire that got released for Pfizer. We should be expecting those for Moderna as well. Those came out from the CDC, I think, on late Wednesday afternoon, evening. So we still have documents kind of trickling out, and we're going to try to keep you all informed as much as possible as they arrive. Because their vaccines aren't quite here yet, especially the Moderna one. There'll be more information coming even after that gets released as things get finalized. They want version control in some cases, so they're trying to get that. But we do understand folks are preparing. So we have lots of forums. We had an open office hours this morning too, where we answered lots of questions too. I'm going to send out the forums that we have approved. There's a website out there. I can put it in the chat that they're posting all the approved forms as well. And theirs are trickling in as they become available, but I just put that down in the chat. So explore that. It has the checklists for documentation, which are just kind of guides. And then also the forms you can use for employees, patients, and VAMS patients that, or maybe community members that are non-BENs. So we have all that ready for you. And then when we do get into EHR documentation, what you're going to have is an EHR quick note, an order on your order menu for the vaccine, and that'll fall under your standing order that you'll have to root through for local signatures and stuff for your medical director. And then you'll also have an EHR super bill with associations that'll get all the rest of your documentation. Once the BYM patch is onboarded, that information documented in EHR for anybody with an RPMS EHR chart that's not an employee, but anybody with an RPMS EHR chart will transmit through that interface to the National Data Warehouse, which then goes to the CDC. There is a requirement to report within 24 hours of providing that vaccine, and that's part of the agreement from the CDC when you choose IHS as your jurisdiction for the vaccine. So there's no wiggle room there. It has to be reported either through VAMS or through your documentation. And we do have a couple of COTS creating an interface similar to the National Data Warehouse to report that way too. So once they get that onboarded at their COTS programs, potentially, then they can transition away from VAMS as well. So ultimately, VAMS will sunset after we finish the 2 doses of people who fit into that employee health category for sure. If we need them, the community one, we can stand that one up as well. And then tribal health will go into RPMS EHR for those sites. And then the COTS will have another advanced clinic for that. So I know that's a long story, but I just wanted to throw that out there.
Thank you, Robin. We're going to turn it back over to Dr. Brown. I know there was a lot of information. If there's other questions.
Yeah, any other questions about anything, Super Bowl predictions?
Hey, Dr. Brown and Steve.
Hi, Dee.
Quick question. See, I did see your VSafe post within the chat, and I'm probably sounding like a parrot these days because I've talked to USET staff and some IHS staff on an alternative to the VSafe app that we could get a report back from. Right now, I'm assuming we're not going to get a report from VSafe.
No, you will not.
On that. And I don't know what Cherokee's utilizing, if they're utilizing something, but this is the chief. I do got to take this call.
While Dee is taking that call, let me just say a little bit about VSafe. This is really just a CDC program. Anytime a new vaccine is released, they want to do post-market surveillance. This isn't technically post-marketing surveillance because the vaccine has an emergency use authorization, not licensed as a regular, fully authorized FDA product. But it's basically the same thing. They're looking for maybe rare side effects that didn't show up in the 30 or 40,000 people that were in the phase 3 trials. And I think they're also just looking to see, in a general population, do people experience basically the same side effects that they did in the trials? In both vaccines, something like 80 to 90% of people had some kind of local reaction, sore arm. That was the main local reaction. Pretty high percentage of people, especially with the second vaccine, have other side effects like body aches, joint aches, headache, feeling chills and feverish. So they're just tracking this. This is totally voluntary. People don't have to do it, but I'm doing it. It's kind of fun. Takes about 90 seconds to sign up, and they send me a text every day, and it takes me about 30 seconds to report. The problem is it doesn't do the clinics any good. There's no feedback loop to the clinic for that. So it's my understanding, Dee, that you would like to do follow-up on all the vaccine recipients when you start vaccinating people next week, probably. Yeah, that's a noble undertaking. Sounds pretty labor intensive, but I don't think it's a bad thing to do. I think it's good, and I think it will probably also help people with their vaccine hesitancy.
So I want to speak to that really quickly. We developed, or in the process of developing 4D, and we can make this available to others if they like it. Like a questionnaire in RedCap, and the nurse can go in daily and run a report. And so the nurse doesn't have to follow up with that patient. She can look at that report and filter out any yes to adverse events that she needs to. So if everybody has a no and everything's fine, she doesn't need to reach out to that patient. But if there's a yes, then she would be tipped off, other than probably a sore arm or something like that, that she may need to do some follow-up to free up her time. I will say, we built this very quickly. There was a very quick turnaround time for this request. So it's at this point, it's probably only appropriate for staff and people who will actually complete the survey without having to do, push notifications via text and all that. We haven't built that process yet. But it's just kind of a down and dirty system that we can pass off to you. Tori is in the process of Tori and Amani both are putting the finishing touches on that. And Dee, we were hoping Imani Tori today to have that to Dee today. Close of business, or are you thinking?
I believe today will be fine.
Okay. All right, so we should have that. And again, it's probably just going to be an interim system until we can get something a little bit more robust built. But I think it would be useful for staff that are getting the vaccination.
This is Dr. Johnson. That question, the great question. It reminded me that there is an area that I think Robin, with all the information she gave us, forgot to cover about the adverse reactions and recording those. Robin, can you take a couple of minutes, because I know we're running close to time, to talk about the adverse reactions and how they are to report those through the systems? If you're talking, you're on mute.
Sorry, double muted again. So yeah, theirs is the vaccine adverse event reporting system. And that is going to be an FDA CDC. Sorry, trying to get rid of this other phone ringing. So it's an FDA CDC joint website that you can document your adverse reactions that are reported. If it is a normal reaction that's included in the EUA, the emergency use authorization, you do not have to report it in theirs. But if the patient does report an adverse reaction, then it is something that you can go into. I can put that in the chat as well. We did add a hyperlink in your EHRs to theirs and VAMs. And if you are a federal site, we also have iStar where we also report those into as well. But theirs is the adverse event reporting system that will be used to track those adverse event records.
Thank you.
Great.
So this is Max Boykin with IHS. Because we were just talking about adverse reactions, I do want to mention that because this is a brand new vaccine and there's a lot yet to learn about it, please remember to review your medical emergency protocols for dealing with anaphylactic reactions with this new vaccine.
So I know we have quite a few people who may not be EPIs or healthcare providers on the call. And well, even if you are, there's a whole lot of rumors and speculation out there regarding this vaccine. So I wanted to open it to see if anybody had any, I heard that sort of questions. Dr. Brown is unfortunately sitting down and he will not show his tail that is growing because of the vaccine. So there is that side effect that you need to be aware of. And that was a joke. But I just kind of wanted to lighten it up and open it for any sort of misinformation that you may have heard or just questions.
Well, Christy, we don't need another tail. Thank you for that joke.
Well, I've heard, it's my understanding that contract health services will pay for tail removal. So, I mean, I think we're good.
Well, that's great.
I don't know. That seems more like a priority 5 to me.
Priority 5. Can we move it up? Thank y'all so much.
Hi, this is Ben Kelly. I have a comment for Dr. Brown. On one of your slides, and maybe this is just because it's the first time I saw this in the range of efficacy, it had like 61 to 93. And I guess maybe seeing 61 for the first time in print sort of caught me off guard. Is that, I mean, I know they have to list all of the range, but is that maybe a little low?
So that's actually a statistical calculation. That's the 95% confidence interval. And the reason it's way low like that down at, what was it, 61.4% up to 95.5. That is completely a mathematical statistical calculation. It's not really its effectiveness. That means that they are 95% sure that that somewhere in that range is the effectiveness for people over 64. So, what can be said about that is that we're pretty sure that it's at least 61.4% effective in people over the age of 64. The reason for that wide range is because there weren't that many people in the over 64-year-old age group that actually got sick with COVID. So when you have very few numbers, it spreads out the confidence range, the confidence interval. But I suspect that if and they are going to do follow-up for 2 years on all these vaccine trials. If you had bigger numbers, that confidence interval would shrink and would probably be closer to the 86.4%. You'll notice that some of the other confidence intervals, like if you look at Pfizer's 95.0 and the confidence interval there is 90.3 to 97.6, they had a lot more cases, a bigger number to plug in. And so that makes the confidence interval shrink. And I am not a statistician, so that's my feeble attempt to explain that statistical thing. But if you want to quote something, just quote those numbers, that are outside those brackets. It's the Pfizer vaccine, they said, was approximately 94% good in people over the age of 55. Moderna is 86% good in people over 64. Again, that's an apples to oranges comparison because they're different age groups, but that's how the trials came out.
Yeah,
Does
you
that
can
answer
think
your
of it a lot as like for polls, the plus or minus when they do polling, 95% plus or minus 2% said. It's similar sort of concept.
Right.
Thank you.
I'm sorry, but I'm going to have to jump off the call right now. I have another lecture to give in 2 minutes. So I appreciate everybody's attendance, and don't let me be a party pooper. If people have more questions, we've got plenty of people to answer them. All right.
Merry Christmas, Dr. Brown.
Thank you. Merry Christmas to all.
Merry Christmas to you all too, from Choctaw.
Do we have any other questions, final questions that we need to address?
This is Nancy again. I just have a question. Maybe it's already been answered or asked and I zoned out. Since has any tribes reported any kind of adverse reactions anywhere across over the 12 areas from the vaccination of the Pfizer?
This is Dr. Johnson. I have not received that information. I think on a local level that they're going to deal with it on an area level and then allow for it to go up to headquarters. And so it's going to take a few days, given the fact that they probably just started vaccinating yesterday or day before yesterday. And so it'll take a few days before we'll start hearing, but I've not heard anything about any major reactions thus far.
Any additional questions? Lastly, there is the survey in the chat box to help us improve the sessions. If you will take a moment and fill out the survey, it's very brief, about 5 questions. It'll help us improve the sessions and get some ideas for next session, which is going to be January 15th. So that is going to be our next session. We don't have any topics, so if you feel free to suggest some topics for us, and we will do our best to cover them.
Yeah, I just want to speak to that very briefly, Brian. We were discussing this actually this morning about what our topic should be, and January 15th seems so far away that at this point in time, there's going to be so many changes and so much information out. We're going to wait a little bit. Suffice it to say, I'm sure it will be something regarding COVID vaccination. But we'll keep you posted on that.
Okay, well, if no one has any other questions or comments, we can go ahead and close for today. Thank you all so much for attending today's COVID Echo. If you have any following questions or concerns, you can email me at bhendricks@usetinc.org or anyone else on the staff. Thank you all. Have a wonderful holiday and be safe.
Thank you.
Thanks.